Hi, everyone, and welcome to our panel on the most vulnerable populations at Texas Biomed's Global Health Symposium 2023. I wanted to start by introducing our moderator for this panel session, Bexar County Commissioner for Precinct 1, Rebecca Clay Flores. She is a staunch community advocate here in San Antonio and lives a life of service. She has spent 15 years serving in education and nonprofits, from teaching 5th grade and GED ESL in San Antonio to starting an educational nonprofit. She has also taught English in Tampico, Mexico at the State University and worked at a private university in Tennessee where she recruited college students to take a year off as community service volunteers. As commissioner, she has championed funding for construction for residents who lack water in their communities and allocated funding for the San Antonio Mobile Mental Health Collaborative for schools in Precinct 1. And so many more projects that she has done in our community. I am so honored and privileged to have her here with us, as well as our esteemed panel. So I am going to turn the mic over to Commissioner Clay Flores for the rest of the presentation.
Good morning, everyone. All right, I'm so happy to be here. My name is Rebecca Clay Flores. I am County Commissioner for Precinct 1. How many people are here locally from Bexar County? Yay! Okay, and so anyone from out of the country? No, just you flew in from out of the country. Wow. Oh, okay. All right. Okay. I was like, wait, where did you fly in from? So thank you so much for being here. So for those of you who are from here, I went to Brackridge High School, which is a large inner city high school. Grew up in poverty. Went to Princeton, majored in religion and African American studies. Then I got a master's in education at Harvard and have also gone to seminary and done some other things in education and locally did some work in public health, specifically research in social determinants of health. Because where I was working, I felt like they were just playing lip service and not really trying to get things done. So I just kind of did that on my own, which didn't make people happy, but it's kind of what I do, right? And so now as county commissioner, it's just been a privilege for me to be able to have a platform to advocate for certain things. So oftentimes when people introduce me when I'm speaking at things, I'm like, why did they say that? Nada que ver with what I'm talking about. So I'm just going to say briefly about these women who we have on our panel today, and then I'm going to give you guys a minute to add anything else you want the audience to know before we start questions. Okay? So we have Sarah Lovenheim, who flew in to be with us today, and she formerly served as the top public affairs official overseeing healthcare communications for the Biden administration during the height of the pandemic. She's going to talk a little bit more about that. And then we also have Corinne Reyes, who is here locally, the director of health equity with the YWCA in San Antonio. And then virtually, do we have her picture up? Something? TV monitor. Is Afnan on virtually? Okay. Okay. Hi. Where are you right now, Afnan?
I am in Buffalo, in New York.
Oh, okay. I thought she was out of the country. Okay. But anyway, she's here with us, and she has previously worked with nonprofits in Pakistan, working on education, gender, and juvenile justice, and has also worked on mental health policy. So please give them a round of applause. So Sarah, let's start with you, and if you can just take a minute and just talk a little bit about what you want the audience to know in relation to what we're going to be talking about this morning.
Sure. I'm thrilled to be here, and thank you, Commissioner. And thank you to all of you who are here in person and also to those of you who are joining us from afar. I'm here today from the Washington, D.C. area. As the Commissioner mentioned, I served as Assistant Secretary for Public Affairs under President Biden and Secretary Javier Becerra at the U.S. Health and Human Services Department. It's the 90,000 person agency that's responsible for overseeing everything that hopefully matters most at the end of the day in the healthcare space, in the public health space. HHS, as it's called, as its nickname, oversees also CMS, NIH, CDC, and all of the sub-agencies in the health and public health space. So I'm here today to talk about something that is very close to me in my professional work, which is evidence-based communications. I'll get into that in just a few minutes, but essentially, any public health strategy today, in my mind, requires an evidence-based communications response. It's not enough just to drive communications in the traditional sense. You have to target, you have to test messages, and you have to measure the response if you want to actually make an impact and have a chance at saving lives. So that's what I'll talk about shortly, and thank you again. Great. Okay.
Hello? Yes, okay, awesome. Did you want to ask me a question first?
No, just a minute about your background and why you're here today.
Okay, awesome. My name is Corinne. I'm the Director of Health Equity for YWCA. I am a registered nurse. I've been a registered nurse for over 15 years. I know most of us think nurses work at the bedside, and that's all that they do. But I did work at the bedside for many years, and I did work in data healthcare analytics for many years. And it always was kind of a mystery to me, like, why do these people keep ending up in the ER, keep ending up in the ICU, when I could have done something about this before they ever even got here? So that's how I ended up in the public health space. I work, again, for the YWCA. Our mission is to eliminate racism and empower women, and we do that through several core programs. We're kind of like the boots on the ground people. So we take all the wonderful work that Sarah does, and we take it into the community, try to change it up so that it's perfectly fit for that specific community's culture. We work side by side with people on a one-to-one individual level to ensure that they have education, healthcare that kind of drives them to retrust the system that we have broken for them. So that's a little bit about what I do. So yeah, that's
Thank you. Afnan, 1 minute about your background, what you want us to know.
Yes, thanks for having me here. I am very, very happy and glad to be part of this panel with all of you. So I think about myself, this session is very, very relevant, very important to me because it sort of brings into perspective the work that I've done. In Pakistan, I worked on generally a nonprofit organization with communities on ground in gender education, juvenile justice, death penalty. And it was actually during the pandemic that I realized that a common factor, a common thread in all the work that I was doing was actually mental health. And that is what basically drove me into choosing my global policy studies program at UT Austin and focusing specifically on mental health policy therein. With respect to that, I think the most important pointers that I would have for today is first to understand the interconnectedness of health inequities, and then to also emphasize the importance of integrating mental health into primary healthcare, especially low resource settings.
Okay, thank you. All right, so let's get started. First, I want to know the backgrounds of some of the people who are here. So can you just shout out what your professions are, why you're here? This is a small room, so don't be shy, or else I'll start calling out people based on their...
27 years in public safety with San Antonio Fire Department, and I'm a business consultant and strategist.
And why are you here today?
I am representing Clinical Trials of Texas, and I recently was hired on by them to help bring diversity into their clinical trials.
Okay, great. Thank you. Somebody else. Thanks for being the brave first one. Somebody else. Philanthropy. In what sense? Okay, then we need to talk after this because... Cool. Thank you for being here. Somebody else. Yes.
Tiffany Smith with Texas Kidney Foundation, and I'm here as an advocate and also as a person who has programs that are data and evidence-based. And we're doing the same thing and outperforming Super Bowl commercials in our engagement. So
Yay. Thank you. Thank you for the work you're doing.
I just want to put it out there. Rebecca Clay Flores, Commissioner Rebecca Clay Flores, is the fuel behind us being able to do that. So this system is doing it.
Thank you. Anybody else? Anyone else? Yes, sir.
EMFN. I work for Gender Health, and I focus on fistula in Africa.
Cool.
Fistula.
What part of Africa?
9 countries in Africa. From
Okay.
Mali, Senegal, Guinea, Nigeria, Rwanda.
Okay.
DRC.
And where are you based now?
I work out of Washington, D.C. office, but I live in Dallas.
Okay, great. Thanks for being here. One more person. Isn't this fun to see who you're sitting next to? Yes, ma'am.
I'm Barbara Taylor. I'm from UT Health. I'm an HIV care doctor and researcher, and I have the honor.
Cool. Thank you so much for being here. Okay, so Sarah, why don't we start with you? Tell us a little bit about the campaign during the pandemic and how once you guys realized the specific communities and who wasn't getting vaccinated, who wasn't why infections were higher in other areas and how the campaign focused to try and yell and be like, you have to do this. We want you to live. So tell us a little bit about that.
Sure, thank you. Just to step back for a minute, I just want to make one point at the top that I think sort of sets the table here, which is that you can have all the public health tools available in the world, but if they're not reaching people, if they're not getting into the hands of the people who need them most, and if people aren't trusting their safety, their efficacy, then we have to ask ourselves, what are we doing that we could be doing differently? So at the start of the pandemic, near the onset, the Kaiser Family Foundation published a study showing, sadly, the disparity gaps in COVID's impact across the country. And in Washington, D.C., for example, where Black people account for 45% of the population, sadly, they were accounting for 59% of deaths. In Louisiana, where Black people account for, I think it's 32% of the population, according to Kaiser back then in 2020, they were accounting for more than 60% of deaths. Wow. So it was very stark to look at the numbers at the onset of the pandemic, and it gives me the chills to even think about it today, just how dramatic the disparity gaps were. Latino communities also were disproportionately at risk, as many of you know, for COVID's wrath. And so when the Biden administration began, we had our work cut out for us, and we really had to think hard and strategically in real time about how we could tackle COVID. And communications is, of course, just one channel of fighting any public health scare, but it was an important one, again, because people aren't using the public health tools like vaccines and therapeutics as they become available, we're missing the mark. So in the Public Affairs Division at HHS, we had a team committed to conducting research. We surveyed the nation every single week of the pandemic to understand how the same set of messages were resonating with different audiences. And so we tested messages in multiple languages, ultimately more than 14 languages. We worked with a team of researchers to make sure we were bringing people together from across the country of different demographics to sit down for focus groups, thoughtful, long conversations to understand what made people decide to get vaccinated, what were the myths about vaccines that were swirling out there in various communities. And the researchers we partnered with worked to ensure we had representative samples. So in other words, we looked around, we saw the polls outside of the federal government showing people, sadly in many cases, didn't even trust their doctor as much as a friend or a neighbor or a local community leader when it came to making decisions about their health during the pandemic, because there was so much that was unknown and uncertain that a lot of misinformation was spreading very rapidly. So this team became known as the We Can Do This campaign, and We Can Do This was our motto for so many reasons. So after testing messages, given that the virus was evolving and the variants paths were still unknown over many, many months at any point in time, we couldn't stop that work of testing messages. And then once we were testing the messages, we had to figure out how to deploy them in a way that would reach different audiences in hard-to-reach pockets of the country. Because you can only send so many people out on the ground. You can only run so many TV ads on the airwaves when you have at times very limited resources. So we had to be really creative, and we established probably what was considered, untraditional for the federal government, really strong, I would say, private-public partnerships for the first time. So we cultivated a network of 1,000 organizations that were committed to helping engage their networks on the ground in various pockets of the country. We looked at geographic maps every single month to understand how COVID was rapidly changing and affecting different communities differently on the ground. We also enlisted celebrities to help. Eva Longoria, for example, helped us reach the Latino community at one point. Corporate entities like McDonald's at one point put vaccines.gov as the URL on their coffee cup holders.
Isn't that funny? McDonald's helping with public health. That's great.
So it was necessary. I think a lot of companies realized, the public health scare was hurting probably their bottom lines. I don't have those numbers, but I think, certainly closer to the beginning of the pandemic and maybe a year in, there was broad recognition that, with everybody staying home, with the impact on families, whether you had a loved one in the hospital or not, everyone was struggling. So it was a whole of government response really to the pandemic, but also a whole of society response was required. So we also built a network of what we called trusted messengers, up to 20,000 people across the country who voluntarily signed up, raised their hand to step up and spread the word about vaccine safety. These were people who would tell their neighbors about community health centers that were holding mobile clinics, often outside of working hours, so that people who were, on the job and couldn't get that time off could get vaccinated. Community health centers, which there are about 1,400 of across the country, particularly serve low-income communities. So it was especially important that we fostered a strong relationship with them. Pharmacies agreed to hold mobile vaccination days where they sometimes offered, benefits to their customers for getting out and getting the vaccine. The list goes on. So it was a Herculean effort, I would say, and it required this evidence-based communications approach. How many of you are familiar with what that means? I know you raised your hand earlier. Okay, well, it's good to see a few hands, but I'm also glad not to see more, so we can talk a little bit more about it. It wasn't only that we had to test the messages to make sure they were culturally sensitive and that they would resonate with people and that they would combat some of the myths and fears about vaccines and talk to people in terms that people understood and related to, but we had to find also ways to measure the impact of everything we did. So if we held an event, we wanted to know how many people actually got vaccinated at that event. If we ran a digital ad, we wanted to know how many people actually saw that ad. If we were hanging posters, or if we were, creating posters of superhero images for children's hospitals to hang, let's say, in their rooms, we needed to know, how many hospitals were actually using those signages that we created to help spread the word about vaccines. And so we found mechanisms to track the results of all of these efforts to understand what worked well and what needed to work better. And ultimately, at the end of year one in February of 2022, there was some good news, at least at that time. We had closed disparity gaps in vaccination rates. Among Black adults, 80% of people had gotten their first dose. Among Latino adults, 77% had gotten their first dose, and that was compared to 75% of white adults. This was February 2022. And that was a 20-point increase from about a year before. So I think, communications, particularly evidence-based communications, was a really important ingredient in trying to reach as many people across the country as we could in those hard-to-reach pockets. Certainly, the work was cut out for us. In year two, there were far more limited resources. There was a more apoplectic public, and there was still, a good number of Americans who were at high risk for COVID's impact and who needed to get the booster or who needed to get that second dose in some cases. But evidence-based communication, I hope you all are left with thinking, it's not only critical for a pandemic, but it's a critical approach to communications for any major health challenge that we face as a country. Right now, there's a big effort underway, again, in the public-private partnership space to tackle mental health. And I know one of my other panelists is going to talk to you a little bit about that too. When I was at HHS, we launched the first 3-digit suicide prevention hotline. It's 988. And just like 911 when it started off, 911 has thankfully become a number that I think most children learn at a young age is what they need to dial in case of an emergency. It's at least what I've told my 2 kids. But now, we've got 988. And so again, we have an opportunity to figure out how to reach people who are struggling most. That number is only as good as, the people who use it to call when they need help. It's a mental health crisis line. It's one of the many ways we're working as a country right now to strengthen mental health. But it's one of those tools that needs to get in the right hands. And thankfully, with the digital landscape, the way that it is, as noisy as the media world can be and as fractured as it can be, there are ways to track, what people are Googling, for example, as far as the help they need. There are ways to track
let's go back and talk about mental health.
Sure.
Because I want to talk about that. So I just want to comment on when she started speaking, you talked about how we can do all this good work, right? We in this room who are involved, who care, who are educated, who have access, who have connections, we can do all this work. And if we do all this work and we know about all this work, it's meaningless if the people who really need to know about it and to have access don't get that access. And so that's just really important. That's why we're here today talking about it, because the pandemic totally is not over. So we need to continue to talk about it. But so often we find ourselves in trials, whether personally, family-wise, or as a community, or in this instance, as a world. And then once we get out of it, we forget about it. And then when the next time it starts, we're going to be in the same issues and drama. But for those of us specifically here in Bexar County, myself and other community educators have been complaining about the lack of equitable access in the southern part of Bexar County before the pandemic. We were already talking about these things. Then the pandemic happened, and then people couldn't deny because of evidence-based and statistics like you were talking about. So it's just really important for us not to, so before I ran for county commissioner, I was working for the local health department. And one of my things that I was complained about is that it seemed like they were just more concerned about checking off box and say, okay, I did it. I did that presentation. I went to that part of town. I gave out those pamphlets, so I checked off. And now I can present a really nice PowerPoint to a group like you all or to the city council without really having impact in the community. And so if we just act like we just want to, take a picture on social media and say that we did this, that's not good enough if it's not reaching the people it needs to reach. And so that's why we're here. And so thank you for the work that you have been doing. So can you give us maybe a couple of analogies or stories of what happened here locally and how we reach specifically women's health and our most vulnerable communities? Because the YWCA is located on the border of my precinct, kind of like on the south side and west side, which the pandemic hit really the hardest in this community.
Oh, yeah, absolutely. So at the YWCA, we were very lucky to be one of the sub-recipients of grants from many of the organizations that you were working with. And that kind of allowed us to really build a true health equity department that was fully functioning and fully working. And I say that because instead of just being like, okay, we're going to go out to this community and we're going to talk about COVID and we're going to give you a vaccine now, we couldn't do that because the trust was already broken in these populations. We had to come at it from a more holistic approach. We had to say, we're going to come out to you and we're going to offer free mental health services. We're going to let you see a gynecologist. We're going to let you see an OB. We're going to offer all these services. So we were able to consult and contract with doctors that we said, okay, we're going to pay you $300 a day. It doesn't matter how many patients walk in that door. That's what you're getting paid, and you're going to see these people for free. But because people could go in there and get all these services at the same time and know that we weren't going to push anything down their throat, but they were going to talk to a doctor and a nurse and an MA that might say, hey, you should really get vaccinated for COVID as well. Now they're able to trust the message because we're able to offer everything at one time. They don't have to go to any place else when they leave here. And, maybe even we can say, we have some gift cards in the back to cover your gas, because that it has to be that holistic way of handling people. Because if you don't know where your gas is coming from, you don't know where you're going to live at, you don't care about a COVID vaccination. So we have to make sure that we're meeting all those needs. Sometimes people will come to us and be like, I just need a blanket because I'm cold. And we're going to go to Walmart and buy them a blanket. So we take, all that messaging and we kind of make it, the boots on the ground effort so that people know that we actually do care about them. We do care that they can't afford their medication. And we have some gift cards in the back that they can take to the pharmacy. And we do care that they don't have a refrigerator in their house. And we're going to go to Walmart and help them go get one. We care about all those things. And then they're more able to trust us in telling them about, hey, you also need a mammogram and a COVID vaccine, and you need prenatal care and all these other things that we're telling them about. So,
Afnan?
Yes.
Okay. Can you talk a little bit about kind of the most vulnerable populations and low-income populations, not only here, but internationally, and how we communicate not only during the pandemic, but moving forward in terms of public health?
Yes, of course. So I think here is where lines get a little blurry, because in high-income countries like the US, minorities, people with disabilities, and with serious mental illnesses have disproportionately suffered from health disparities. And that is a part of the story where we're very generally well aware, because that is the statistics that is presented to us. But in low and middle income countries, the challenges become even more astounding. For example, if you consider Pakistan, there is an acute mental health workforce shortage in Pakistan, with an estimated only 1% of the health budget devoted to mental health. The psychiatrist to population ratio is dangerously low at, let's say, one psychiatrist for nearly 500,000 people, against a recommended ratio of one for every 10,000 people. That means that for an entire massive population of more than 230 million people, the country has less than 500 psychiatrists and only 4 psychiatric hospitals in total. So I think this puts a lot of already vulnerable people at further risk of slipping through systemic cracks. Because barring areas where the elite reside, neighborhoods comprising underserved populations, which is by far the majority, are more likely to be far from hospitals, clinics, doctors. This is a problem made worse by a lack of public transport to get to medical providers in high-income areas. And from there on, stigma and lack of social awareness further aggravate the problem. And just like we're having this conversation right now, during the pandemic, yes, the gaps were highlighted, but it's also about the situation of health inequities that we were in when we entered the pandemic as well. And I think especially in low and middle income countries, in low resource settings, we did not have the resource capacity to deal with a pandemic at such a large scale to begin with, which is why people who are already vulnerable, we're talking about people with disabilities, we're talking about people with serious mental illnesses, we're talking, let's say, even about women who are pregnant or who are new mothers, who we know from research are particularly vulnerable, and any impact on their health is also going to have long-term impacts on their child as well. So I think all of these intersectional identities then cause further vulnerability, impose further vulnerability on these individuals as well, making it harder in the pandemic to really cope with the health inequities as well.
So how do we, as professionals in this room who care about global health and public health, how do we make sure that this doesn't happen again? Obviously, we can't control the next pandemic, but if you watch the news or if you just live on this planet, it's like there's more and more drama and trauma, community trauma, national trauma, globally hitting us. So how do we make sure that the way that the pandemic hit us and the way that we reacted or didn't react or lack thereof or slow reaction, how do we make sure that we learn from the best practices from the last 3 years and that this doesn't happen again? That's for all the panelists. And if anyone has a burning desire to add something, then jump in. Raise your hand.
Okay, I'm going to say something that may not be like super popular, but we're going to have to get really brave and address the structural racism that has put us in this position in the first place. And unless we do that, we're just going to keep having the same effect over and over again. I don't know if any of you guys know what the Flexner report is. So, long time ago, the American Medical Association hired William Flexner to determine what should a medical school look like. And when he determined what a medical school should look like, he disenfranchised every medical school for Black doctors, because he determined that they were not sufficient to train doctors, and that the only way that we needed to give health care to African Americans in this country was to make them just healthy enough so that they didn't get white people sick. And that is the legacy of the healthcare system that we live in. If we continue on this pathway, we will continue to make sure that people of color are just healthy enough that they don't get other people sick, And then we'll continue to have things like the pandemic that we just had, because you're not giving them the baseline health care that they need on a regular basis. You're not giving them the preventative services that they need to not get sick in the first place. You're not giving them the education they need to know how to do what to do when they do get sick. Or you're not giving them the access to those things either. So unless we go back and really address those things and remove them out of our system, and they're so pervasive that even us as clinicians, we don't know that we're doing them. Yes, ma'am.
I was going to say,
Yeah.
just to piggyback on what
Yes.
you said,
Uh-huh.
it's not even just a mentality, but it is in actuality policies that are in place.
It's policies, yes.
Kidney disease is not diagnosed until stage 3 has been maintained for 3 months. It is detected in patients in stages 1 and 2. The best therapeutics that we have that can treat kidney disease and be most effective are in stages 1, 2, and 3. They're called SGLT2Is.
Yeah.
They're called SGLT2Is. African Americans, Latino Americans, they do not know about SGLT2Is. They've been around for 10 years. What this commissioner has allowed us to do is create the database evidence and measure educating people about this. We've been in 39,000 homes. 37,000 of them looked at the commercials all the way through, 362 commercials. We have better engagement than Super Bowl commercials. We are getting to them and educating them, but the policy that has doctors and practitioners diagnosing at stage 3 after 3 months, and let's be clear on that, you've lost over 50% of your kidney function at that point.
It's irreparable at that juncture, so it doesn't matter
that's
anymore.
Right. And it's a major thing because you're
So-
talking about the expenses. They rise by 40% between stage 3 and 4. So policies must change. And the attitudes towards trusted agents like Corinne's organization and mine. Do you know what we did during the pandemic? We reached out to HHS. We couldn't get HHS to come along with us. So what we did, my husband and I, is we liquidated our 401k, invested the money took out a $475,000 loan and started screening our people and brought the best tests in the country here. And she helped us get the rest of it done.
Well,
She did.
So, and I talk about how, it's us as a community, right? Because
Yeah.
we talk about policy, but it takes, so when she says I've pushed for funding. I go where she tells me to go, like for interviews and stuff to talk about preventive health. So it's all these things, right? It's structural racism, classism, but it's also us as a community. Because we ourselves have to step out and say, I'm going to fight for my own preventive care.
Yeah.
I'm going to exercise. I'm going to watch what I'm putting into my
And fight for our own
into it.
people.
And fight for each
Yeah.
other, right? Whether or not like you're offending me personally,
Yeah.
but you're offending maybe a group that I don't identify with, but it goes against me as a human being. And so we as a community need to speak more about that. Did you want to comment on that, Sarah? Do I need to go back to the question?
Oh, and I wanted
Okay.
to tell you one
How do we
more
make sure
thing.
this doesn't happen again? That's the question. For
I wanted to tell you
Afnan
one
and-
more thing. So we started going out for vaccines. We started going out and speaking to the actual churches and community centers and just showing up with our kids and got vaccinated at a local place with our kids in 78207 to let people know we believe in this. So the trusted agents, you can't discount them and just replace them with whoever everybody feels comfortable with, some doctor, because that's not necessarily going to be useful.
Thank you. I'm glad you brought that up. I do think trusted messengers and organizations like the YWCA and so many others were extremely critical. I think we have a big challenge too, in addition to tackling the roots of a lot of our public health challenges when it comes to disparities. I think we also have a challenge, sadly, with Congress not investing enough in preparedness. And preparedness is really key. I think a lot of the panels yesterday touched on all of the work that's happening in the public health space today across the country to try to detect other, infectious disease that could potentially, be of some sort of challenge. Hopefully not, but that we should be at least monitoring for the future. And sadly, there just isn't the extent of investments that I think is probably needed for the future right now. And so I know a lot of people are working to change that. But, from a communication standpoint, I would just say, we talked a bit in the beginning about all of the work that happened domestically. Our global relationships and partnerships are also essential for preparing for the future. I do think as a country, we worked very hard to restore global partnerships to understand, what other countries were facing when it came to the COVID-19 pandemic. But I think all of those relationships and the communication, with everyone from the World Health Organization to embassies around the world and organizations in the public health space is going to be critical to continue to make sure we get ahead of anything in the future.
That's key. Get ahead, not to be reactive. Yes, sir.
Yeah.
Oh, I'm sorry. Someone had their hand up before. And then Afna, I haven't forgotten about you.
Yes, Chris Velasquez. So as my tenure with the San Antonio Fire Department, I was the program manager for the mobile integrated healthcare. And the significance of that we were the lead agency for the fire department for the COVID response. Anywhere from testing to vaccinations, we administered, I don't even know how many hundreds of thousands of vaccines at the Alamo Dome. To my point is the significant hurdle that we had was with the geriatric population. So we couldn't find them, and no one really knew where they were. And they were homebound, not just homebound, but just seniors. They were too afraid to come out. And so nothing has really been done to address that to this day. And that is a very frustrating, because we talk about these things, right? We have these sound bites and slideshows, and I've been to city council, I presented, and they love to hear that. We helped X number of people, blah, blah, blah.
That's what I'm talking about.
Yeah, that's why I retired.
Thank you for affirming what I just said.
No, you were 100% correct, and I wanted to raise my hand then. I was like, yeah. So my point being is, do y'all have any foresight about how we could address? I think the time to build that community trust with the geriatric population is now, not the next pandemic, which will happen, right? We know it's not if, it's when.
Right.
And I think, the significance of that is we start that trust now. But point is, how do we find them the next pandemic?
Well, right now, we're working on a couple of grants that are very directed at the geriatric population and making sure they get vaccinated, not just against COVID, but your shingles, your pneumonia vaccines, et cetera. The major hurdle that we're running into now, because we host bingo events and we go into their homes and we meet them where they're at and talk to them. But the number one thing I always hear is, I can't afford that vaccine. The shingles vaccine is hundreds of dollars, and there's no coverage for that. The same thing with
$400.
Yes, there's no coverage.
I just
for
gave
that.
my mom money to get hers. So.
Yeah,
I know how much it costs.
Exactly. And if you're uninsured, what are you going to do at
But
that point?
insurance does not cover the shingles vaccine.
That's true too. Yeah. And we've tried multiple ways to get it covered. But right now we're kind of moving towards working with policymakers to figure out ways to get coverage for adults vaccinations the same way children's vaccinations are covered. So that's kind of where we're doing it at. So I don't know.
And I just want to touch on that, because we haven't finished my original question. I want to go to AFNAT, but I just want to touch on that. When we talk about community and a global community and global citizens, it also takes us to know who our neighbors are and who's in our community. So when I was running for county commissioner, and I was block walking in the height of the pandemic. And so as I met old people who came to open their door, then when I got into office, and I called George Hernandez, who's the CEO of University Health here, and I said, I need 100 slots. That's when it was only for like 65 and over and all these specifics. And I was like, I need 100 slots for precinct 1. And he was like, give me the names in the next 24 hours. And so my team and I started calling around, and I went through my list of block walking, and I went and was like, because I would write notes about like, this little old lady told me she's HIV, AIDS, and all this stuff. And I would call them, and we were calling people to get them those slots. And it takes work, individually knowing who, because when you're talking about really old people, and if they don't have children or people who are looking out for them, then it's going to take the neighbors to know who those people are. And so now, as we go to neighborhood associations, as we go to our senior centers, and we reach out now, I would say, at least my office in precinct 1, we have a better pulse of who the seniors are. But you can't wait. So like I said, when I was working for the health department, and we were on a call, and I was saying, well, have you reached out to certain communities? And one of the assistant directors at the time said, well, no, but if you have any contacts, let me know. And I was like, now is not the time to build relationship when you're in the middle of a global pandemic. You have to have those relationships now. And that's the lack of trust that specifically low income and communities of color don't have for the systems. So then when you're trying to say, we have this vaccine, you need to get vaccinated, they're like, I don't trust you. You ain't putting that in my body. And understandably so. And so we have to build that trust in those relationships now before the next drama thing happens. Okay, Afnan, now finally, how are we going to make sure this doesn't happen again?
Yeah, I think I really resonate with a lot of the things that are being discussed right now. Because for long, minorities have disproportionately suffered from health disparities. And I think yet attempting to rectify inequities without a holistic recognition of how forces of oppression are codified into policy will not really create the desired impact. Because as we're discussing, institutional racism and lack of trust, which we were talking about earlier in the panel discussion, discourage many to even seek care. And even if someone had access to healthcare, mental health care in particular, the workforce available was not representative of the population that it served. As we were discussing about the Flexner report as well, these are the repercussions of that era where we do not have a workforce that representative of the population that it's actually serving. And the result is disparities in quality of care, over-medication, underdiagnosis, lower patient satisfaction, workforce burnout, and overrepresentation in coercive environments like prisons. And such a glaring health inequity is a recipe for the most vulnerable to fall through systemic cracks even without a pandemic. We were not prepared for a pandemic. And at this point, if we're not going to work on the interconnectedness of health inequities from all perspectives, from a social perspective, from a health perspective, we're not going to be able to really deal with another pandemic in this situation. And specifically, since we're talking about Texas, let's say, for example, understanding that there was a Commonwealth Fund report that found that inequities were consistently the most pronounced in Texas. And the group ranked each state's healthcare to examine disparities in access and quality, which revealed disparities amongst the worst in Texas for racial and ethnic groups. That meant that it was, if I remember correctly, it was that our state ranked in the top 40% in the treatment of white individuals, but at the bottom quartile for the same healthcare system's treatment for Black and Latinx individuals. That has pronounced impact on people, their trust levels, whether they seek care or not, and whether they have access to quality healthcare or not. And if we're going to prepare ourselves to really respond in a better way for the next global health crisis, we need to make sure that the status of our health inequities is being worked on, and that is a priority for us.
Let's kind of pivot to mental health, because I would dare to say, like we're saying, my question was, how do we make sure it doesn't happen again for the next thing? I would say mental health has been an epidemic in our country and in the world for a long time, because it's something that we can't see. And little by little, more people are starting to talk about it, but it's still something that's very stigmatized. It's still something that people have lack of access to. So let's talk a little bit about that. Afnan, why don't you kick off, because I know you've done a lot of research and work on that, and how you think this is affecting us as a community, and how we need to, what we can do better in terms of mental health.
Yeah, I think the onset of the pandemic really did highlight the global mental health crisis that we were in. Suddenly, we realized that 1 billion people, that is 1 out of every 8 people, lived with a mental health disorder. From a mental health perspective, we also knew that some were more vulnerable and at risk than others. And I think this is where a lot of work can be done. Because as of now, even though there has been a lot of conversation on this, but as of now, mental health still sort of lags behind physical health, especially in low and middle income countries, where we're not at par with physical health in terms of funding, in terms of research, in terms of really prioritizing that within our health policies as well. With, let's say, just 1% of the health budget devoted to mental health in Pakistan, there's very limited scope that we can really do. So I think the most important thing right now would be to devote funding to research and to really expanding the initiatives that we have of integrating mental health into primary care, especially in low resource settings. That would be one very, very important step that we can take for mental health.
Okay. Do you want to talk about 988?
Sure, thank you. Just like we talked about with tackling COVID, communication being a key, I think communication is really important in the mental health space. I think, it starts with children and connecting with schools and other education communities because kids learn at a young age what the quote unquote social norms are. And stigma tied to mental health is a particularly big problem in certain communities. I know that a lot of school systems are taking steps to hire more mental health counselors, but often, it's up to the school educators themselves, not necessarily those who are even skilled in mental health, to let people know about tools and resources available. And parents, too, have a responsibility to teach their children, it's okay to get help. If you know anyone struggling or if you're struggling, here's how you can get help. So that's where I would say it starts. And then, of course, fostering those relationships with organizations that are working really hard to tackle mental health stigma in varying communities.
And I agree, it definitely starts at the home, but then sometimes we have parents or guardians who have their own mental health issues and often don't know how to ask for help. So my background is in education. And one of the hardest things that I've had to do professionally, even all the hard, really ridiculous things I've done in politics recently, but was when I was teaching fifth grade, I had to physically restrain one of my fifth graders, 10-year-old, because she was what we called a runner. Her parents were getting divorced and she was suicidal. And she was literally trying to run off of campus into the street. And the other teachers are freaking out. They didn't know how to handle it. They didn't know what to do. Another 10-year-old who I'm still in touch now. My kid, my fifth graders are now grown, but I'm still in touch with her. And in one of her writing assignments, and she wasn't in my homeroom, but in one of her writing assignments, she obviously had some issues with sexual abuse, and none of the teachers knew how to handle it. They were like, I don't know what to do. I can't handle. So I would take those things on simply because of my experience in childhood trauma. And I had finally gotten counseling in my 20s. And so that's why I took it on. And so since then, I have been advocating that we need more therapists in our schools. And so it's something I ran on. And finally, sometimes, people were asking me at the work that I've done fighting for migrant kids in a shelter here because the governor came down to say some really horrible lies about us. And I was a new county commissioner of 3 months, and I went to go fight with the governor. And people were like, "Oh, wow, how'd you do that?" And I was like, "This is the work I've always been doing. The difference now is people put microphones in my face, and I have a title after my name. But this is the work that I've always been doing. So I'm really proud of the fact that I had advocated for a pilot program in Precinct 1 for $4.75 million to partner with nonprofits and schools, public independent school districts, to hire more therapists and social workers. Because when I was at Brackridge High School here, I wish I had access to a therapist. Growing up in the inner city, single mom, minimum wage jobs, we didn't have a car. How in the world was I supposed to get across town to the north side where all of the care was when I was a kid, and still to this day? So that's why it's important to have mental health based in the community. And then, unfortunately, we're having fun in here too. We're just not as loud as them. And unfortunately, after the Uvalde shooting, then the rest of the court realized we need to put more money into this. So we passed $20 million for all of Bexar County schools, and we already passed. The last contract we did was in February. And yesterday, I was actually at a mental health conference. Center for Healthcare Services had a mental health conference here, and I was there. And I happened to sit next to a couple of the therapists from Southwest Independent School District, and they said, because of you, we are opening a mental health center at Southwest ISD. And so those are the kind of things that we need to do to kind of start to talk about at an early age. Because yes, when we're adults, it's never too late to ask for help. But man, it could have saved us a whole bunch of drama and trauma to be engaged at our earlier age. So that's definitely something we need to continue to do. Did you want to talk about mental health as well? Did you want to touch on that?
Yeah, I mean, just briefly, yeah, you touched on a little bit that is a stigma in a lot of cultures, particularly cultures that we deal with at the YWCA. And I know a lot of us grew up in the same generation where if you want to cry, I'll give you something to cry about, and boys don't cry. And we all grew up in those kind of households because, you know, that's what it was. So we kind of have to untraumatize ourselves first before we can deal with the upcoming generation. And so right now as an organization, we are getting trauma-informed care certified to ensure that we are sensitive to the needs of our community and we know how to properly see and identify things and deal with them. And I definitely recommend anybody in the organization that you're working with to go for trauma-informed care certification. And even as an individual, University Health offers amazing classes. So just you as an individual can, you know, become informed.
And mental health is just so difficult because if your friend, you know, gets diagnosed with something or cancer, you're like, oh, let me bake them some brownies, right? Someone says, I'm depressed. You're like, oh, let me not reach out to them. I don't want them to rain on my parade or they're going to bring me down. And those are things. So we need to catch ourselves of what we do as a community. And I think, do we have 10 minutes left? We have 10 minutes left. So I'm going to open it up for questions before I have our panelists close out with their final statements. Yes, sir.
Thank you very much. My name is Iyama FM, and like I said before, I work with Engender Health on obstetric fistula and so on. And I was interested in this because I wanted to find out, you know, if people realize that in addressing vulnerable populations, that you sometimes do more harm than you actually do good. You know, so do they determine that and so on? And secondly,
can you give me an example of that?
Yes.
Because oftentimes we talk and we say these things, and people are like, yeah, and they don't know what you're talking about.
And fistula.
Am I right, y'all?
In obstetric fistula, and just for definition, obstetric fistula is the injury associated with prolonged obstructed labor, and you become incontinent. And it could either be urinary incontinence or fecal incontinence. And this is very rampant in many countries in Africa. Now you have, so we have a program that addresses that in different countries. And you have doctors who come from the West.
Yeah.
And they go to these places and they want to fix that. They want to repair the injury. But they end up spending 2 hours, 3 hours on one patient and walking away and don't realize that they didn't do that much because they don't have the experience to do that. But because they come from the West, they have the clout. And you end up going to do repair, and the woman is more damaged than you. So who do you leave her with? You created more problems. In other cases, they look at an injury, and because it is very complex and they cannot repair it, but they don't want to admit that they cannot repair it. So what they do is they now do a diversion. And so this lady has the colostrum, carries a pouch of either urine or feces around for the rest of her life. But meanwhile, if you understand these issues, you know that the complexity of a fistula depends on the available skills. And so when people train for a longer time, they can fix what they thought was a complex fistula or irreparable fistula. And so the question is, why don't you counsel this woman to say, let's deal with your situation as it is, let's manage it for some time, and we will find those with the necessary skills to come and handle it. So instead of doing that because they're vulnerable, the people are weak, they're not empowered anymore, they need help.
Right.
And
Thank
so
you.
you come in with your Western ideas and clout, and you think you can do it, but then you end up with a problem.
Who did you want to direct your question to? Which panelist?
Well, for me, I mean, it's generally everybody that is in the development sector that is working. So if you feel there is nothing wrong with owning up and say, hey, I don't have the skills to actually deal with this, or I'm coming to learn, and let those who are there teach me, but don't go knowing that you can solve the problem when actually you're creating more problems.
Thank you.
Thank you.
Anybody else? I just want to give other people, you guys are not shy at all. I want to give other people opportunity in case, someone in the back. See, I know her, so I know she's not getting her feelings hurt by that.
Yeah, thank you very much. My name is Sam Kariuki. I work with the Kenya Medical Research Institute, but I'm on a short sabbatical with the Ohio State University. Now, I think the word global health really needs to be global in it and how we respond to this, because just looking at how we responded in Africa in the last pandemic, where the Africa CDC came together, courtesy of the African Union, to be able to bring together all the requisitions for vaccines, even for diagnostics. That means we can also have solutions from home-based institutions. So I think, and this is where I really like the conversation going on here, that some of these solutions are inbuilt in the societies where we are. We can solve our own problems. What we need is support and recognition that there are solutions within the society. I really like the way that we must look inwardly. How have these people been surviving before? How come that before we came, they were still there?
Right.
So what new solutions are we bringing? We need to support inbuilt solutions. That's my point. Thank you.
Thank you so much. I feel like these are more comments instead of questions. This is good. Any other comment or question? Anyone else in the? Here's one person. Go ahead, sir.
Yeah, my name is Henry Obefon. I work with Masena Therapeutics. My question is, I've heard about trust, and I've also heard about collaboration. I'm not going out of this place today having the answer of trust being dealt with. How do we deal with trust in our society? I just want to know that, and also want to know how we deal with collaboration within the health sector and other bodies to deal with some of the issues that we've laid out today. Because I was here last year. I don't want us to come here every year, probably say the same thing, and we are not able to deal with those things. And we come back the next year, we are saying the same thing.
Thank you.
Go ahead. Go, Sarah.
I think misinformation is a really big phenomena today that definitely requires more attention from organizations in the public health space, and just people who are concerned and have a voice and know how to raise it on different platforms to right wrongs and get the facts out there when myths circulate or when misinformation spreads at rapid pace on social media. Anybody today, given how fractured our social media space is, can find a platform to speak up. It's definitely harder to navigate the media landscape today than it once was, but I think we all have a responsibility to help combat misinformation when we see it. I know that's not the solution, but it's a step and it's an important one. And all of us in our respective organizations or places of work have an opportunity to help do our part.
I just want to say, basically, I think that I'm pretty basic, right? So trust, just like when you're building trust in a new relationship, whether it's a professional relationship or dating relationship, it takes time and communication. And I think we as a community, as elected officials, professionals, we need to commute better and more often and continuously. So when these things happen, we already have those relationships and we can already trust. We only have a few minutes left, so we have a virtual question that's going to be read.
The question is, in Texas, some reports show Latinos compromising 80% of these orphans that were generated by COVID. Is there assistance available for the survivors, counseling, or other mental health support, other types of support? And this is from Dr. Carrion.
Afnan, do you want to tackle that?
Can you repeat the question? Because I think there was some audio lag.
Yes. So the pandemic generated many COVID orphans. In Texas, some reports show Latinos compromising 80% of these orphans. Is there assistance available for the survivors, counseling, or other mental health support?
For Texas specifically, my work is generally centered on low and middle income countries, but I know that they're doing a lot of work to expand mental resources in different sorts of settings, including expanding mental health resources to telehealth as well, to reach people in all backgrounds and all settings as well. So that's one thing that I've heard that Texas was specifically working on. That said, I think there's a lot still that we need to do, which is not maybe going to be possible in the immediate short term, but possibly in the longer term once we realize that we have to unpack a lot of the damages that policies have done in the past. So I hope I'm answering your question.
And I would also say, I would say yes. Something that I just recently learned that I didn't realize, Medicaid actually covers mental health and counseling. And so I think that's really important, that whoever the children are, if they're talking about orphans, I would think that a lot of them might be on Medicaid, and that is something that is covered in the state of Texas. So that's really, I think, really good. So we only have a couple minutes left. Actually, we have 1 minute left. So we're just going to go around and ask our panelists to take about 30 seconds if there's anything that you want to leave with the audience or something that you didn't get a chance to say.
Thank you. I hope all of you, wherever you work, will think about marrying evidence-based communications tactics with your research work, your public health-related work on the scientific side of things, or otherwise. I think it's critical that communication starts early at the onset of any research or development work in the public health space, whether we're thinking about other health challenges related to maternal health or reproductive health care. There's, a wealth of opportunity to do justice to everybody we can reach that way. Thank you.
Thank you.
I guess I just wanted to leave everybody with question everything you come across, and then talk to people. And that's going to really help us move forward in the public health space. So, how was it?
Afnan?
Yes. So I think my last thoughts would be we've all heard that we must address health disparities if we aim to advance social justice. This is the part of the story which we've heard countless times. And while social justice is the utmost priority, in fact, addressing disparities is equally important to the entire society because it is crucial to the overall national economic prosperity. And I think the most important message here is that inaction is going to be costlier because lack of resources isn't going to save you money. It's going to result in stress, loss of productivity, and job absenteeism, globally costing us trillions of dollars. Like, for example, ignoring mental health treatment has a big opportunity cost. When mental health professionals are unavailable, it produces a serious spillover cost by loss of economic productivity, but also by shifting burden to more expensive and often unprepared environments like prisons, public hospitals, emergency rooms, and homeless shelters. So I think the most important thing for us just to realize from a mental health perspective is that mental well-being is critical to all. Even those who may not be suffering from an illness will be impacted indirectly.
Thank you. I would just like to say in closing, personally, that being in this room with with an all-female panel and the way that the audience was engaged and the diversity of thoughts and professionalism that you all represent gives me hope that we as a community will continue to fight for these things and that we can make the world just a little bit better. Because oftentimes I feel very alone. I'm the first woman of color county commissioner in Bexar County. I'm the only woman on the court. And oftentimes I feel like I am the only one fighting for things like mental health or even make a decision on the court and move forward and don't keep trying to go back. And so oftentimes it feels like I'm the only one yelling and fighting about certain things and that it's falling on deaf ears. So being in this room gives me hope. I hope that you guys leave with some hope to continue to push forward. I want to thank everyone who joined us online. Thank you for the panelists. Thank you for flying in to be with us. And I hope you guys continue to have a wonderful weekend and continue to make this world a better place for your neighbor and for our neighbors across the pond. Thank you so much.